So as we know, today's today's discussion is on emergencies in palliative care. So palliative care, I mean, sometimes when I mention emergencies in palliative care to some of my friends, so they give me a bewildered look. So palliative care is usually considered as like a very calm, comfort care. So, but we do have emergencies in palliative care, like in any other medical specialties. So today we are going to just have a bird's eye view of some of the emergencies in palliative care. So can we go to the next slide, please? So what is an emergency? So the definition of emergency would be, per se, any condition that poses a threat to either the life or quality of life of the patient without an immediate intervention. So it may not be life-threatening conditions alone. Anything that can poses a serious threat to the quality of life also can be considered as an emergency. Next slide, please. So when we go to emergencies, especially in palliative care, so the things that we should consider are, first thing is we should actually try to foresee the emergencies. So the first thing when a patient comes to us is to ask the question of whether there is a risk of developing an emergency. For example, if a patient comes to you, suppose the patient is having a carcinoma breast with bone metastasis and she is having back pain, you should actually naturally think about the chance of the patient going into a malignant spinal cord compression or a spine metastasis. So that you should always have that thought in the back of your mind. So the first question to ask is there a risk? Unfortunately, if the patient has developed an emergency, the next question to ask would be if it is reversible or not. So, for example, there is no in palliative care. We are always considering the patient's comfort and dignity at first. So whenever there is an irreversible condition, there is no point in going to great extents, doing multiple interventions which are not beneficial to the person. So the next question to ask would be whether it is reversible or not. So if the condition is reversible, the next question should be, is there a meaningful benefit if we reverse it? For example, a bedridden patient who is at the end of life, and one morning you find that there is a weakness in her right lower limb. So what are we going to do about it? Maybe we can reverse it, but whether that is worth a meaningful benefit, that is the next question to ask. So the final question would be, what does the patient or family want? So whether the patient or family want to go ahead with the treatment. So rather than thinking about a disease itself. So when we see in isolation, many conditions can be an emergency. So as in the example that I mentioned earlier, malignant spinal cord compression or an acute onset of a neurological weakness is a medical emergency. But we have to have some context. So what is the patient's situation? Whether reversing it or going about treating it whether it will produce any meaningful benefit, and what does the patient and family want? That is the next question that we should ask. Next slide, please. Excuse me. So we are trying to go through some of the emergencies according to the various systems. So some examples would be, in neurological system, it would be spinal cord compression, increased intracranial tension and delirium. A respiratory system example would be an airway obstruction, whether an acute or a chronic thing. Vascular would be SVC obstruction, superior vena cava obstruction or hemorrhage. Metabolic would be hypercalcemia and hyponatremia. Skeletal system would be pathological fractures, and pain would be pain crisis and opioid overdose. So explaining everything in detail regarding the management and investigation would be definitely out of scope of this presentation. But what we would try to do is we'll give a brief overview of all these situations and how we go about treating all these things, so that you will get an idea and you will get a base on which to build on. Is that all right? Yeah, so we'll go to the next slide. So the first thing we'll deal about would be malignant spinal cord compression. Malignant spinal cord compression is one of the most common palliative care emergencies that we come across in the OPD. So it occurs in 3 to 5% of the cancers. The most common solid tumors that produce malignant spinal cord compression would be prostate, lung, and breast. Hematological malignancies like multiple myeloma, which primarily affects the plasma cells and thereby the bones, can also cause malignant spinal cord compression. Most common site would be the thoracic spine. So it can have pain, mechanical instability of spine, and neurological deficit. These all can be the presenting symptoms or the issues related to malignant spinal cord compression. Next slide, please. Can we move to the next slide, please? Okay, so coming to the pathophysiology. So the pathophysiology of malignant spinal cord compression would be, so this, as you can see, this blue and yellow dot in the thing would be the spinal cord and the dural space. So when a tumor enters the dural canal, it would actually go around the spinal cord in a path of least resistance, and finally there would be compression of the spinal cord. So there is a chain of events in this situation. So first there will be a compression of the spinal cord. The compression will result in venous stasis. When there is venous stasis, whenever there is stasis, there is edema, right? So along with this edema, there will be increased secretion of interleukins and prostaglandins. Of the stasis, interleukins, prostaglandins, everything would result in a vasogenic edema. So once this edema progresses, it will eventually lead to ischemia and finally leading to infarction. So that is the usual pathophysiology of spinal cord compression. Next slide, please. So the sign coming to the signs and symptoms of malignant spinal cord compression. Back pain is the most common presenting symptom or spinal cord compression. It happens in 95% of the patients. Radicular pain can happen in 40% of the patients, and sometimes they can have neurological symptoms and autonomic symptoms. This back pain is very important because it can be the usual presenting symptom of malignant spinal cord compression. And again, more important would be it usually occurs days or weeks before the onset of neurological status. So as we will come later in this presentation, the most important prognostic factor in a malignant spinal cord compression would be the pre-incident ambulatory status or the motor status of the patient. So whatever was the pre-treatment motor status of the patient. So whatever is the motor status of the patient at the time of treatment would be the most important prognostic factor. The worse the motor status of the patient at the time of initiation of treatment, the worse the prognosis is. So if we can treat a patient when he is completely mobile, when the motor status is completely normal, there is a very good chance that we can maintain that. So reversing an already established motor weakness is always difficult in case of malignant spinal cord compression. So that is why back pain is very important, because it occurs weeks or even days before the development of actual neurological deficit. It is very important to treat this as a potential symptom. So as a general rule, whenever a patient with a malignancy comes to you with a back pain, always treat that as malignant spinal cord compression unless proven otherwise. So when you do a clinical examination, some signs that you can elicit is spine tenderness, which can be again an important symptom even before the development of neurological deficit. And when the neurological deficit happens, there can be multiple neurological and autonomic signs for that patient. Next slide, please. So the diagnosis, gold standard would be an MRI because it will give adequate picture about the status of the bone, the spinal cord compression, thecal sac indentation, and all those things. X-ray can also be used whenever there is a very definite collapse or compression of a bone. X-ray is X-ray is usually beneficial. So the one thing to keep in mind here is whenever there is a compression or a spinal cord compression at one vertebral side, there is always a 30% chance of having that compression in one more site. So isolated malignant spinal cord compression can happen, but again, having another site is also very likely. So whenever you are suspecting a spinal cord compression and doing an imaging, always make sure to screen the entire spine, because you may be able to find more than one areas of compression or potential compression for that matter. So that is an important thing in diagnosis. Next slide, please. So coming to the treatment, so initial treatment would be bed rest. So if there is a malignant spinal cord compression, we should actually keep the patient immobile until the treatment is initiated, because we don't want to increase the damage. So for pain, you can give opioids and adjuvants. So what about NSAIDs? So do we usually give NSAIDs for patients with malignant spinal cord compression? Anybody in the comments or in the chat box? So we usually give opioids and some adjuvants, because when there is malignant cord compression, there can be always some neuropathic pain. So some adjuvants would be helpful in that regard. So NSAIDs can be very good tool in whenever there is a bone fracture or acute inflammation and all those things. So the reason why we don't routinely give NSAIDs is, so whenever there is a malignant spinal cord compression or neurological deficit, we usually start them on steroids. So even if there is no neurological deficit, when the patient is taken for radiation, we'll come to that in next slide, we usually start on steroids. So steroids and NSAIDs together are usually not recommended, because there is an increased risk of gastrointestinal bleeding. So that needs to be kept in mind. Somebody has Dr. Chavi Arora, we like to, yeah, that is correct. Because steroids, the thing is, if there is no neurological intervention, there is no immediate indication to start steroids. But if we are starting the patient on radiation, we would definitely give it prophylactically. So if there is a neurological deficit, definitely steroids are best. So if there is bowel and bladder involvement, we may need to give laxative, digital rectal evacuation, other rectal measures. If there is urinary retention or incontinence, we may need to catheterize the patient. These are the treatments that is available. So next slide, please. So as in all things, we always do, there is a 3-step approach for all the treatments that we do in palliative care. First is correct the correctable. Second is non-pharmacological measures, and third is drugs for symptoms. So we should ideally treat the cause in this thing. So one, as we mentioned, steroids. Now, how do steroids work? So whenever steroids is mentioned in palliative care in cancer, there is one thing that usually accompanies this, which is peritumor edema. So whenever there is a tumor, there is usually some peritumor edema. And whenever there is an obstruction or compression, this edema also plays an important role. So whenever there is an obstruction or compression, if we give steroids, that it will take care of the peritumor edema and inflammation, and usually the compression or obstruction reduces in its extent. So the definitive treatment would be surgery. So surgery and fixation of the spine. If surgery is not possible, we usually give radiotherapy. And for highly chemosensitive tumors like lymphoma and multiple myeloma, chemotherapy is also an option for such patients. Next slide, please. So steroids, as I mentioned earlier, anti-inflammatory and anti-tumor effects. The primary effect that we are looking at is to reduce the peritumor edema. So recommended dose is 16 to 24 milligram per day. So once that definitive treatment is initiated and completed, we can actually taper the dose. And important things to consider is gastroprotection and concurrent NSAIDs. Avoid concurrent NSAIDs. So the important thing about steroids is, as we give it for a longer time, its effects tend to deteriorate. So you should actually give it in pulses, in the sense you have to give it for a short period of time of like 5 to 7 days, and then try to taper it as quickly as possible, because the longer you give it, the less effective it is. And the side effects again starts increasing after you give it for a particular period of time. So always provide gastroprotection with steroids and avoid the use of concurrent NSAIDs. Next slide, please. So other treatment options are radiotherapy, surgery, and chemotherapy, as we mentioned earlier. So whenever possible, surgery is the treatment of choice, because it will give an additional element of stability also. So if you fix the spine, stabilize the spine, so there is an additional benefit of stabilization. If you give radiotherapy, it will actually shrink the tumor and reduce the compression, but the stability is again an issue. So whenever possible, the first line of treatment would be surgery. So chemotherapy for highly chemosensitive tumors. So next slide, please. The prognosis, as I mentioned earlier, the pre-treatment ambulatory status is the most important prognostic factor. Again, that is why it is always important to treat a back pain in a patient with malignancy as potentially serious. So unless proven otherwise, treat a back pain in a malignancy patient as malignant spinal cord compression only. So time of initiation of, first thing is pre-treatment ambulatory status. The second thing would be the time of initiation of treatment from the onset of motor deficits. We usually give a time of 48 hours. If you for the treatment to be most effective, you should initiate it within 48 hours of the onset of neurological deficit. The earlier would be the better. So that is again the second thing that is usually associated with a good prognosis, an early initiation of treatment. Next slide, please. So this is one thing that is whenever a patient comes to you with a bone mets, spinal mets, there can be multiple spinal mets in many patients. So when to give treatment and when not to give, when can we give the patient an observation is the question that we usually ask ourselves often. So this is something called SIN score. This is spinal instability neoplastic score, which has multiple criteria, multiple elements like location, pain, bone lesion, whether it is lytic, mixed, or sclerotic. Spinal alignment, vertebral body collapse, and posterior spinal element involvement. So based on this, you can actually score. So a score of 0 to 6 would be 0 to 6 would indicate a stable spine. A score from 7 to 12 would indicate a potentially unstable spine, and more than 12 would be an unstable spine which needs urgent intervention. This is something that we should keep in mind. So whenever you have a spine mets and you know what to do next, so this can be a guideline. Next slide, please. So the next emergency in the neurological system would be increased intracranial tension. It can be because of metastasis to brain or meninges, or it can be caused by a primary brain tumor. The most common causes would be lung, breast, and melanoma for brain mets. So it is said that the most common brain tumor is mets. So the incidence of brain metastasis is much more common when compared to the incidence of a primary brain tumor. And the symptoms of increased ICT, as you would all know, would be headache, vomiting, seizures, altered sensorium, etc. Next slide, please. So again, treatment, steroids. So whenever there is brain met, there is always usually a peritumor edema. So as we mentioned earlier, to reduce the edema and inflammation, we give steroids. So osmotic diuretics is something that we used to give routinely, and even now sometimes we used to give, like mannitol and all those things. The problem with osmotic diuretic is it is said that it reaches a plateau very quickly. The effect of osmotic diuretics plateaus out very quickly. And so the primary drug of choice would be steroids, and osmotic diuretics, although there is not a lot of evidence for that. Some centers still give that, but it can be omitted also. And the treatment will again depend on the number of lesions, size of lesions, etc. If there is a single lesion or single brain metastasis, the treatment would be surgery. If there are multiple lesions, it can be radiotherapy. SRS is stereotactic radiosurgery. So even if that is small lesions, I mean less number of lesions, we can consider stereotactic radiosurgery, where we concentrate a high amount of radiation to that particular brain met. So whole brain RT is irradiating the whole brain. When there is multiple mets scattered throughout the brain, we would always irradiate the entire brain. That is called whole brain RT. Again, chemotherapy and targeted therapy. The problem with the traditional chemotherapy agents are that they don't usually cross the blood-brain barrier. So it may not be that much effective in brain metastasis. But newer targeted therapeutic agents, there are a lot of agents that cross the blood-brain barrier and which can be effective in brain mets. So especially in adenocarcinoma lung with the brain mets and all, there are multiple cases where the disease is managed without radiation or any local interventions at all with this targeted therapy alone. So that is one thing to consider. So analgesics, usually what we give is paracetamol and NSAIDs. The problem with opioids is technically all opioids can decrease the seizure threshold and make the patient more prone for seizures. And tramadol is more notorious in this regard. So whenever opioids are indicated, we usually prefer morphine than tramadol. But if that can be managed with paracetamol and NSAIDs, that is well and good. So adjuvants can also be given as required. Again, when you are giving adjuvants, if you are giving antidepressants like amitriptyline, etc. as adjuvant, so always keep in mind that theoretically all antidepressants also will reduce the seizure threshold. So you may want to stick to something like a pregabalin, which is also an anti-epileptic and which will not reduce the seizure threshold. Next slide, please. So having completed the CNS, we are coming to the respiratory system. And respiratory system is airway obstruction, the first thing that we have discussing. So it can be intrinsic or extrinsic compression by a tumor. For example, it can be a lung tumor in the parenchyma that is actually compressing on the bronchus and obstructing, or it can be an intrabronchial tumor that is causing an obstruction. It can be acute or subacute. Next slide, please. So we are going to subacute airway obstruction. So subacute airway obstruction usually presents as shortness of breath and stridor, which is again an inspiratory finding. So subacute basically means that it develops over or an amount of time. It's not an acute airway obstruction. It has a period of development. So management would be again oxygen steroids for the same reason of decreasing the peritumor edema and compression. Opioids can be given and benzodiazepines. So the idea of opioids is whenever there is breathing difficulty, I think you must have come across this in your course. Opioids can, especially morphine, strong opioids like morphine can reduce the work of breathing. So in titrated dose, it can reduce the work of breathing and make the patient feel better. So there is always a persistent question of respiratory depression along with morphine. That is not usually happening. So there was a huge meta-analysis of all the studies giving morphine for breathlessness, and they have found that the incidence is less than 0.5%. And it almost always never happens in a well-titrated situation when we are giving morphine under the supervision of a trained palliative care doctor. And again, it is very rare with oral medications unless the patient has taken it with intention of self-harm. So it is said that with oral medicines, it doesn't rise to a particular level which is enough to cause respiratory depression. It doesn't go to a particular blood level which is sufficient enough to cause respiratory depression. We should be a little bit more careful when we are giving via the parenteral route. But again, if it is a sufficiently well titrated dose, there is absolutely no incidence at all. We can say that. So that is one thing. So radiotherapy, again, like in spinal cord compression or brain metastasis, radiotherapy, the role of radiotherapy would be it actually shrinks the tumor, it reduces the edema, it can relieve the obstruction. And tracheostomy, whether to do or not, is another question. So again, in a lower respiratory tract obstruction, tracheostomy is not going to help. But in an upper respiratory tract infection, tracheostomy can be a life-saving measure. But the problem with that is, if the initial tumor, the primary tumor is not curable or in the end stage, it can actually prolong the suffering of the patient. Later, there are people who have developed tumor recurrence in the tracheostomy site. It can get very messy. So is this something that we should talk about the patient, talk to the family, and then take a call on rather than directly taking the patient for tracheostomy? So if that's a very well treatable tumor, and if the tumor has been showing good response, that is well and good. But in a very progressive tumor which is not responding to therapy, tracheostomy should be a shared decision making rather than just a physician's call. Next slide, please. So second thing would be acute airway obstruction. So this is when the patient suddenly lands up with a severe progressing dyspnea and usually an associated hemodynamic collapse. So unfortunately, unlike a subacute airway obstruction where we have some time to act, this is usually a dire situation where sometimes we can be totally helpless regarding relieving the airway obstruction. So sometimes we may need to concentrate on reducing the distress rather than treating the cause. So in such cases, what we usually is we sedate the patient so that the patient will not be in that much distress, and then family education and support should be provided. So this is one dire situation. So again, the first slide we mentioned about asking about the risk of developing an obstruction. We should be actually clinically sound enough or wise enough to foresee the situation and at least educate the family regarding this. So we may not be able to prevent all these things, but at least if we foresee these things, there can be a time gap for us to sensitize the family and to make a clear picture, give them a clear picture and make a plan when something like this happens. So that is always important. So but once a patient lands up to you like this, there is not much we can do to relieve the obstruction, but we should actually focus on reducing the distress. Next slide, please. So we'll go to the vascular thing. So this is superior vena cava obstruction. This is something that all medical students would recognize. So anybody who has gone through the medical school will recognize these things. So dilated chest veins, facial edema, and all those things. This is a typical sign of SVC obstruction along with the pulseless JVP, elevated venous pressure JVP without a pulse. So next slide, please. So SVC obstruction can occur in bronchogenic carcinoma, lymphoma, mediastinal germ cell tumor, etc. The treatment, again, steroids obviously for acute situations to reduce the compression and edema, we can give steroids, but the definitive treatment would be stenting. So stenting, I mean, I don't know how the availability of stenting may be an issue in many centers, but whenever possible, stenting is currently considered as the primary treatment for SVC obstruction. Previously, we used to give radiotherapy, but the benefit of stenting, so it is said that stenting is usually successful in around 94% of the cases compared to 80% of radiotherapy. So if you give palliative radiotherapy for SVC obstruction, it is successful only in 80% of the cases, whereas stenting is successful in 94% of the cases. So that should be the primary treatment whenever possible. So if it is not possible, you can give radiotherapy. Bronchodilators usually doesn't have much of a role, but again, that use of diuretics is also questionable. So previously, we used to give diuretics routinely for this patient to reduce the venous return, but again, the effect, there is not much evidence regarding the use of diuretics. There are some non-pharmacological measures that we can consider to keep the patient in a proper position to avoid IV fluids through the upper limbs, etc. That can be done. So, but the definitive treatment would be stenting. Next slide, please. So again, another vascular thing is hemorrhage. It can be because of tumor infiltration to blood vessels or marrow infiltration or thrombocytopenia. It can be because of the tumor itself, and it can be also because of the side effect of chemotherapy, which causes thrombocytopenia. It can be minor versus major. Next slide, please. Minor bleeding is basically the situation is like an subacute and acute airway obstruction. Minor is a small bleeding where we can have some time to manage the symptoms. So general measures like transfusions, vitamin K, FOP as indicated when be given. Bleeding control can be done by hemostatic RT or medications like tranexamic acid. That is the first thing that we usually give. Hemostatic RT again can be a very useful tool if we have enough time to initiate that. So one thing about tranexamic acid is, one interesting thing is whenever there is hematuria, we usually do not give tranexamic acid. That is because tranexamic acid usually actually forms clots. So whenever we give tranexamic acid for somebody having hematuria, there is an increased risk of bladder clots forming inside the bladder, and it can actually precipitate urinary obstruction. So we don't usually give it for hematuria, but all other bleedings, tranexamic acid can be an option. Oh, it can be, again, the treatment can be site specific. Argon plasma coagulation is typically used for radiation-induced radiation proctitis or radiation colitis or whatever for that matter. So the issue with radiation proctitis is there will be lot of new blood vessels and telangiectasias, which can be actually cauterized by argon plasma coagulation. In steroid and sucralfate anemia are also other things that are usually given in RT proctitis, radiation proctitis. So it will be management would be site specific and will be aiming at bleeding control along with the general measures. Next slide, please. So major bleeds again is like an acute airway obstruction. When the patient comes with a major bleed, there is usually nothing much that we can do to control the bleeding. Again, our idea is to reduce the distress. We'll give opioids for sedation. One more thing to use is dark towels, because the sight of blood itself will be very distressing to the patient and the family. So in hospitals, we usually use white towels. So we usually, when we anticipate bleeding, we usually keep some dark towels ready. And even at home, we ask the relatives to keep some dark towels ready. Dark blue or black or something like that, which won't actually show the color of the blood. So that can be some way of reducing the distress, because that sight of blood itself can be very traumatic for the family and the patients. Again, family support, counseling. So again, one more thing where it is very important to foresee the chance of bleeding rather than managing it at the point of occurrence. Next slide, please. So another important thing is pathological fractures. Again, as we mentioned in the malignant spinal cord compression, the most common reasons are lung, breast, prostate cancers, and multiple myeloma. Again, treatment would be primary would be surgical fixation, analgesics along with adjuvants, bisphosphonates or denosumab. These basically are bone strengthening agents, which takes the calcium from the blood and deposit in the bone. Denosumab is a RANKL inhibitor, RANKL inhibitor, which suppresses the osteoblastic activity and increases the suppresses the osteoclastic activity and increases the osteoblastic activity. Again, another important thing for pathological fracture is risk identification is very important. Rather than just waiting for the fracture to happen, risk identification is very important. One important criteria for risk identification would be Merrill's criteria. Next slide, please. So this is Merrill scoring system. So based on the score, we can calculate the risk. So if generally we can calculate the risk according to the Merrill's criteria. So it again gives according to the site, pain, X-ray appearance, and size of the lesion. But as a general measure, so whenever there is a lytic lesion in a weight-bearing bone, always be careful, because it is very likely to have a fracture. So even if you take a bone scan, it may not be sometimes visible. So in such cases, if you our plain old X-ray would be more beneficial in such cases. So just take an X-ray and see if it is a lytic lesion and it is a weight-bearing bone. There's always chance of a fracture. Then we can teach the measures like non-weight bearing and all those things, prophylactic irradiation, prophylactic fixation, etc. Next slide, please. So coming to the gastrointestinal system, the first thing would be malignant bowel obstruction. Malignant bowel obstruction can happen in again 3 to 5% of the patients. It can happen anywhere from esophagus to rectum. The most common site would be small bowel. One interesting thing to note is that the most common cause of malignant bowel obstruction is, interestingly, not a primary bowel cancer itself. It is ovarian cancer, because peritoneal spread is most common in ovarian cancer, followed by colon cancer and others. It is usually a poor prognostic factor, especially in an advanced disease. So once the malignant bowel obstruction occurs, median survival is only 1 to 3 months. Next slide, please. So it can be partial or complete obstruction. Next slide. it can be a single level obstruction or a multiple level obstruction. Next slide, please. So we'll go to the pathophysiology of obstruction. So what usually happens is whenever there is an obstruction, the body's way of dealing with obstruction is something like we deal with an obstructed sink. When our wash basin or sink get obstructed, what will we do? We'll try to poke it with some stick or something and then flush it with water, right? So this is something similar. So whenever there is an obstruction, will be proximal distension. The part of the bowel which is before that obstruction would get distended. That will activate the myenteric plexus, and what the body usually does is it actually tries to push harder. It will increase the peristalsis and it will increase secretion so that there is some fluid and lubrication and the obstruction will pass through. But what happens if that obstruction is not relieved is this increased peristalsis and increased secretions can cause some pain, but this increased secretions will again increase the distension. So whenever there is increased secretion, there will be a bacterial overgrowth leading to the production of gas, which in turn again increases the distension. So this will actually go as a vicious cycle. So in this point of obstruction, there can be pain, bloating, nausea, and vomiting. There will be the time of typical colicky pain because there is increased peristalsis and obstruction is not relieving. And some signs like visible gastric and intestinal peristalsis, all those things that we can see at this point of time of the obstruction. Next slide, please. So when this obstruction is not resolved, again, as I mentioned earlier, there will be increased secretion, increased gas formation, the distension will increase. When the distension increases, the body will again try to push harder. So this process go on for some time and finally inflammation will start to kick in. So when there is inflammation, there will be edema. This edema will again increase the obstruction. And again, it goes as a vicious cycle for some more time. Next slide, please. So finally, with all this distension, inflammation, the bowel will start to stretch, and finally there will be ischemia to the bowel. So when there is ischemia, there will be necrosis. Necrosis will lead to perforation and peritonitis, sepsis, multi-organ dysfunction, and death. This is the natural history of an untreated obstruction. So the important thing to note is at this time of obstruction, there won't be the typical colicky pain and all those things. Hyperactive bowel sounds and all those things will not be there. The symptoms will be a distended, grossly distended abdomen with distended bowel and a diffuse pain rather than a colicky pain at present. So this is the final stage of obstruction. Next slide, please. So again, obstruction can be proximal GI obstruction and distal GI obstruction according to the site of obstruction. The ligament of Treitz is that we usually give us a demarcation. The next slide, please. So according to the site of the obstruction, symptoms can also vary. So upper GI obstruction, because the most common symptom would be vomiting, because it is easier to vomit out rather than just trying to push it all the way through. So for a distal GI obstruction or a lower GI obstruction, the most important symptom would be constipation. And later, vomiting will be uncommon because it is very difficult to have like contents accumulating until the small intestine to have vomiting. So the primary symptom would be constipation. In an upper GI obstruction, the primary symptom would be vomiting. So distension is usually absent in an upper GI obstruction because whatever is there will be vomited out, so there won't be any distension. And distal GI distension is a major presenting factor. Constipation is less in the upper GI obstruction and more in the lower GI obstruction. Next slide, please. So investigations to do is, so the basic investigation that we usually routinely do is X-ray. There will be this typical air fluid level. So there is also 3:6:9 rule for distension. So 3 centimeter for the small bowel, 9 centimeter for cecum, and 6 centimeter for the large bowel. So if it is more than that, so it is diagnostic of obstruction, intestinal obstruction. So it can indicate intestinal obstruction. That is one thing that we can think of. X-ray can confirm bowel obstruction, but again, it is not. We will not identify the cause. So the cause of obstruction would be identified by CT. So it has 93% sensitivity and 100% specificity. But whether to go for CT or not will be a case-to-case based decision, because when the patient is very sick and is unlikely to have benefit from any surgical or any other procedures, so taking a CT may not be beneficial. But again, if you want to know the cause and if you plan to treat it in some way, CT would be an ideal thing to do. So one more thing to consider is electrolytes. Whenever there is increased vomiting and all, there can be some electrolyte loss, which can be found out by doing a serum electrolytes. Please, next slide, please. Now, this is a typical air fluid level in a bowel obstruction. Next slide, please. So the non-pharmacological measures, it is generally said that 1/3 of the obstruction would subside on its own if you just rest the bowel. So the first step would be to rest the bowel. So patient can take sips of fluids provided that he's not actively vomiting out. So whether he should require IV or subcutaneous hydration is another question. If the patient is actually planned for a definitive procedure like a surgery or a bypass, it is pertinent to give IV fluids. But if it's an end-stage disease or an end-of-life care patient developing bowel obstruction, IV or subcutaneous fluids may not benefit in the quality of life of the patient. So NG tube, nasogastric tube is one more thing. So in the PG times, whenever some patient comes with obstruction, we used to follow these three things: NPO, IV fluids, and nasogastric tube. So again, nasogastric tube is not necessary unless the patient have large volume vomiting. So if the patient doesn't have a significant abdominal distension or a large volume vomiting, NG tube can be avoided. So NJ tube, nasojejunal tube. So if there is some obstruction at the level of upper GI, like gastric outlet obstruction or upper duodenal obstruction, NJ tube can be beneficial in starting feeding, nasojejunal tube. Next slide, please. So surgical measures are the gold standard of treatment for obstruction. It can be resection, bypass, or stoma. Palliative measures like gastric venting and stents are also being done. Next slide, please. So candidates for surgery would be single level of obstruction, good response to anti-cancer treatment, localized disease, young patients with good performance status, and benign causes of obstruction. Next slide, please. So pharmacological measures. So if surgery is not possible, definitive measures are not possible, we'll do the pharmacological measures. So our pharmacological measures are based on the assumption that although many obstructions present as complete obstructions, a large percentage of them are actually partial obstruction, just presenting to us as complete obstruction. This is the basic idea which we base our pharmacological measurements on. So we usually do a two-step approach. In the first step, we will try to facilitate the bowel emptying. In the second step, if that first step fails, we'll go to the second step where we reduce the symptoms. So in the first step of facilitating the bowel emptying, what we do is we'll give steroids. So as I mentioned earlier, whenever there is obstruction or compression, there is a role of steroids. So steroids will reduce the peritumor edema and the inflammation, and bowel may open up in some patients. So if steroids, we can start. If it is not working after 3 days, there is no point in continuing. We can discontinue steroids. Along steroids, we can give some prokinetics like metoclopramide or domperidone. Domperidone may not be possible because injectable preparation is usually not available. So metoclopramide can be given so that we can try to push the contents through also. But an absolute contraindication of prokinetics would be the development of colic. So if there is colic, if we give prokinetics, there is an increased chance of perforation of the intestine. So again, so if there is no colic, don't give prokinetics. Even if there is no colic, always make sure that the patient is available for monitoring. So whenever there is sudden development of colic after giving prokinetics, we should immediately stop the drug. This is the first step where we try to reduce the obstruction. So if this step is not working and the obstruction is not relieving, we would go to the next step, which is reducing the symptoms by primarily preventing the secretions and preventing the pain. So as we know, as we discussed earlier, increasing secretion will again worsen the obstruction. It can actually cause vomiting and all those things. So to prevent secretions, we give anticholinergics. The usual drugs that we give are buscopan or hyoscine butyl bromide or glycopyrrolate. And even if they are not working, we can give stronger agents like somatostatin analogs like octreotide. So again, along with that, we should treat associated symptoms also. We should give analgesics for whatever pain the patient has. So oral drugs usually won't be beneficial. So we'll give parenteral drugs, and antiemetics can also be given along with this. The preferred antiemetics would be, if there is no colic, we can still give prokinetics. If there is colic, we should stick to other antiemetics like 5-HT3 blockers like ondansetron. Next slide, please. So that is about bowel obstruction. We'll go to some metabolic abnormalities or dyselectrolytemias. First thing would be hypercalcemia. So most commonly occurring in lung, breast, myeloma and lymphoma. So it can happen as a result of bone destruction causing hypercalcemia or as a result of paraneoplastic syndrome causing hypercalcemia. So there are many proposed mechanisms for this: increased parathormone related peptide secretion, local osteolysis, excess vitamin D secretion, etc. Next slide, please. These are all postulated mechanisms. So clinical features would be neurological features like irritability, confusion, sedation, and delirium. GI would be anorexia, nausea, vomiting, and constipation. Renal can be polyuria and dehydration. The patient can be grossly dehydrated if there is hypercalcemia. So next slide, please. So management will be based on the severity. So for management, we'll classify hypercalcemia as mild, moderate, and severe. Mild would be anywhere from 10.5 to 11.9 milligram per deciliter. So I know some centers calculated millimole per liter. This is milligram per deciliter. So moderate would be 12 to 13.9 and severe would be more than 40. So for mild hypercalcemia, adequate hydration would be usually enough. And for moderate and severe, we may need to add certain agents like bisphosphonates, calcitonin, etc. So one thing to keep in mind is, one practical thing is, whenever you are measuring calcium, always measure albumin, because in hypoalbuminemia, we'll have to use a corrected calcium formula, because calcium is usually bound to albumin. So if there is hypoalbuminemia, so you should actually add that deficit to the, so that we'll get a correct value. Otherwise, it will get an abnormally low calcium even in the presence of hypercalcemia. The corrected calcium formula, as you all know, would be measured calcium plus 0.8 into 4 minus serum calcium. 4 is considered as a normal limit of albumin. For that serum, there's a typo. It is not serum calcium. This is serum albumin. I'm so sorry. 4 minus serum albumin. Measured calcium plus 0.8 into 4 minus serum albumin. Next slide, please. So treatment would be increased calciuresis by hydration, and again diuretics. Although we say that diuretics can cause calciuresis, we don't usually use in the management of hypercalcemia. Your reduction of PTH, especially when the PTH secretion is there, we use calcitonin, and reduce bone desorption by bisphosphonates and denosumab when the suspected cause is osteolysis. So next slide, please. So next thing would be hyponatremia. So hyponatremia again is classified as hypovolemic. Hyponatremia is that usually occurs in CCF and congestive heart failure and cirrhosis. Hypovolemic hyponatremia usually occurs in vomiting and diarrhea. Euvolemic hyponatremia, which occurs in SIADH or syndrome of inappropriate ADH secretion. So yeah, coming to the next slide. So diagnosis would be anything less than 135 milliequivalents per liter of sodium would be termed as hyponatremia. Symptoms usually happens when it is less than 120 milliequivalents per liter, but it can happen anywhere. Life-threatening hyponatremia is usually less than 105 milliequivalents per liter. Symptoms can be anorexia, malaise, irritability, muscle cramps, confusion, seizures, coma, etc. Next slide, please. So management, I mean, if there is depletional hyponatremia or hypovolemic hyponatremia, usually supplement. So I'll just touch upon the management of SIADH. So what happens in SIADH is there will be an inappropriate secretion of antidiuretic hormone, resulting in increased free water reabsorption. But so since the other systems of body, other normal regulatory systems of body are in place, like the RAS system and atrial natriuretic peptide are there, so they will actually maintain the volume, but there will be hyponatremia. So this is a euvolemic hyponatremia. There won't be any change in the total body fluid volume, but there will be hyponatremia. So how will you diagnose it is, so clinically the patient would be euvolemic. You will see the urine sport sodium, because even though there is hyponatremia, there will be increased secretion of sodium. So what happens here is there will be increased secretion of ADH. There will be increased free water absorption. The total body volume, fluid volume will increase. The renin-angiotensin-aldosterone system and atrial natriuretic peptide will try to reduce the volume to normal by increasing natriuresis. So basically, they will throw out sodium along with water. So to maintain the volume, they will have to use natriuresis, or throwing out sodium along with water. So there will be increased secretion of sodium in the urine. There will be euvolemia, and there will be hyponatremia. So these are the three things with SIADH. So this is how you diagnose. And important thing is free water restriction. If there is severe, it is severe, we can give 3% sodium correction also. And one more thing is tolvaptan, which is an ADH inhibitor, which can be given in severe SIADH. So again, when we correct sodium, so we should always consider acute versus chronic hyponatremia. So acute hyponatremia is usually as result of an acute event like vomiting or diarrhea. Chronic hyponatremia is long term. In chronic hyponatremia, body is usually used to the development of hyponatremia. There will be symptoms will be less. So it is usually said that in chronic hyponatremia, the problems are usually because of correction rather than the hyponatremia itself. Whereas in acute hyponatremia, the problems are usually because of the hyponatremia itself and not because of the correction. So the thing is, in acute hyponatremia, we can actually have a more liberal correction. In the sense, we can actually correct much faster when compared to chronic hyponatremia, where we should be very, very diligent with our correction. The usual recommended thing is 4 to 6 milliequivalent per 24 hours. If we do a rapid correction, especially in chronic hyponatremia, there is always a risk of acute pontine demyelination, which can be very fatal. Next slide, please. So hyponatremic correction, there is a formula. So basically you find out the total body water, then you find out the sodium deficit, and you find out the volume of 3% saline in liter, and then you calculate the time needed for correction. So, and this is just a formula that you would already know. So rate of infusion would be volume of 3% saline divided by time needed for correction. Next slide, please. So last but not the least, something called pain crisis and opioid overdose. So these are emergencies that can happen in palliative care, but I'm not going to discuss about that in this presentation because I think definitely, I'm pretty sure that you would have this discussion when you're having the pain class. But again, this is something that we should always keep in. Rather than opioid overdose, pain crisis is something that we usually face in the OPDs. Opioid overdose obviously is a very serious thing. So that you will be, that will be dealt with in the pain sessions, I'm sure. So next slide, please. So the take-home message from this presentation would be, so I know that we have covered a lot of things without going in detail to each of this, but the take-home message would be every condition that cause patient distress in an emergency. Patient distress is an emergency. So I remember Dr. Dobert Twycross, one of the pioneers in palliative care, saying that if a patient has not passed stools in 5 days, if a patient has to have constipation till 5 days, that is a medical emergency. So it need not be a life-threatening thing. So anything that can cause significant deterioration to the patient's quality of life should be treated as an emergency. So always the question to ask is, will the intervention result in a meaningful benefit? So we as medical professionals, we always get carried away by the disease itself rather than the whole person. So whenever we are dealing with an emergency, especially in palliative care, so always ask whether that correction or reversal would result in any meaningful improvement in quality of life. And we should always be patient advocates. So before considering anything, so we should always ask what the patient and family wants, especially when it is not something that is completely curable or reversible. So patients' wishes and families' wishes should be always upheld. Next slide, please. Yeah, that's all. Thank you so much. So I would be happy to discuss if there are any questions.
Thank you, Dr. Joel Joseph. Thank you as you mentioned, every emergency or every system issue is important and pertinent, and we have to deal, and you have taken us through, you said it's like a bird's eye view, but you have given an insight on the probable emergencies which everyone needs to be aware of, and also the ways of managing it. Thank you very much. There is one question in the chat box, will embolization or vessel ligation help to stop major bleeds?
Yeah, that can be a possibility. So especially, for example, in gastric tumor causing bleeding and all those things, hematemesis and all. But the issue is we need some time for all these procedures. Embolization is not something that can be, at least in some centers, it may not be something that can be done very, very, very quickly. So Some of the major bleeds that we usually encounter is sudden hemoptysis, sudden bleeding from a lung malignancy, or hematemesis, or even from a head and neck malignancy where there is sudden tumor bleed or something. So if the patient lands up in the casualty in the middle of the night, I think there may not be something that we can give. But again, if you anticipate bleeding or there are multiple hematemesis, we are able to control the bleeding, we are able to transfuse something, yes, embolization can be a useful option.
Thank you. Thank you very much. Anybody else wants to ask something? You can unmute and ask also.
Good evening, ma'am. Good evening, sir.
Yes, please.
I wanted to ask,
Go ahead.
when these patients are nearing their end of life, so if they get these fevers, we know that there is a urinary infection.
Yeah.
The drug is, the organism is not sensitive to oral drugs.
Yeah.
So how aggressively do we titrate the antibiotics? How far do we chase the infection?
Yeah, that is one very good question. So this is a situation that usually faces, especially when patients are on long-term home care where they cannot be taken to the hospital. So that would depend on the symptoms of the patient. So if there is significant, significant dysuria. So the usual symptoms associated with a UTI, for example, I'm just taking it as an example, can be a lower abdominal pain, dysuria, fever with chills and rigor, malaise, and all those things. So if there is an option to give IV antibiotics, and if these symptoms are consistently causing a distress, then by all means we can give. We do give IV antibiotics at home from a nearby clinic and all those things. So that will base on the symptom. For example, but if that is, a patient who is unconscious in the sense not responding, GCS is 3/15, then that patient develops a fever. So then that should be another question, whether that will be beneficial for the patient or something. Because the thing is, when there is long-term end of life care, so infections are one of the things that usually can lead to a patient's death. So this is one of the way that a patient can pass on. So not all infections need to be treated, but again, that decision can be taken on a case-to-case basis. But if the infection is causing significant distress to the patient and or the family, that is definitely an option of giving antibiotics. I'm not able to give a blanket answer for these things, but it should be a case-to-case clinical decision. But yeah, for distressing symptoms, definitely.
Thank you so much.
I think you will also, thank you. You will also have to, that's where goals of care comes into play.
Correct, ma'am. Correct. Yes.
Whether is it the first infection or 15th infection happening like that, and what is the confidence and rapport, and how long the patient has been seen by that particular physician. So who will know, and also what is patient wish, and what is the condition of the patient. If the patient has been bedbound, as he said, GCS 3/15, then explanation, patient's will and wish if expressed, and general consideration. There no medical decision. If it is the 15th infection and the quality of life, patient has not opened eyes for 3 months, everything, it is not one thing. That is where goals of care, assessing the level. No, all we say, we have been telling to assess how serious or what is the prognostic indicator. You will have some more information on the other session which you will have on end of life care. So you can prognosticate. In some conditions, prognostication is obvious and clear. In some, prognostication may not be very obvious as the other. There also the indicators will help you to make a realistic decision.
Absolutely, ma'am. I also wanted to add. So the thing is, the first slide that we had together, I mean, in that discussion, that can be a guideline. Whether it is a reverse, as ma'am told us, whether it's a 15th infection, multiple infections, multi-drug resistant organism. We had one patient who finally, we usually see consults where patients are given colistin, polymyxin, and all those things which are highly costly, and I don't know how beneficial they are when this kind of things. So whether that is reversible is the first question. Whether even that treating that particular infection, what will it give a meaningful improvement in quality of life for the patient and the family? and what the patient and the family wants. So all these 3 points can be guidelines in all such decisions, I think. I mean, although it's a very case-to-case thing, but again, these can act as guidelines in such situations.
Yeah, totally true, Dr. Joel Joseph. Exactly, and your first slide your approach, I think that is something has to be. See, in that approach, first is whether the risk is there, and if the risk is there, how am I going to manage? And if the management is again going to be beneficial, again, like this, how many nth infection, or it could be anything. So, is the management going to be what is the best outcome in patient's best interest? And finally, what does the patient want? See, again, solutions and options may be there, but if that is not said, that is where medical ethics come. So everything you have to put. I think this type of prioritizing and having a protocol, this is something in most of the sessions all of you are seeing. So this is something like what you say, this is the pattern which will be beneficial for us to, as we always say, we will give you all suggestions. Finally, you pick what is the best and put everything. You have to put medical knowledge and the skill what you have, and not forget, or most important is medical ethics. What is that the patient want? What is that, like always, as I say, risk benefit ratio. Put all this in every situation and then move forward. And there's one more question in the chat box. Do we need to take a special consent in handling these palliative care emergencies to avoid medical legal issues? And that one, and there's one more is what is the protocol for home-based palliative care?
Okay, so I'll go. Shall I just deal with the first question, ma'am?
Yes.
Special
Go
consent.
ahead.
I am not sure exactly what special consent. Are you referring to a special kind of consent form or something? I'm not. I didn't get that exact meaning
exactly,
of that.
That's what.
Okay,
See, Dr. You go ahead and tell, and then we'll ask him also.
Yeah, sure. No, I mean, if you are referring to a special consent form or something, we don't usually do that. See, we have a consent form in our hospital. We have a consent form for DNI, DNR, but that usually will be taken for all admissions. So if they are getting admitted under palliative care for supportive care and symptomatic support, we don't usually do resuscitation and intubation or anything of that sort in our department under palliative medicine. So we routinely get a DNI, DNR consent. So that is part of our thing. But for a palliative care emergency, other than that, there is no special consent form. In the sense, we should make the thing is, this is based on the goals of care. We should make the goals of care clear. So yeah, do not resuscitate and do not intubate is one consent that we usually take if we are going that route. So if you want to palliative care management and there is nothing else to be, in the sense of corrective measures need to be done, and if we are focusing on the symptom control and distress of the patient, we usually take a DNI, DNR. Other than that, there is no special consent form that we usually take. I mean, for our IP admissions in our hospital, we have a general consent form saying that not specifically DNI, DNR, the patient has incurable illness and all those things. But no special consent forms. I mean, you treat it like a palliative care disease, but again, DNI, DNR is something that you may need to make clear. But again, there are multiple issues. It's not like a single thing. So there can be, the issue with goals of care is it can actually change over time. There are no fixed. So if a patient actually decides not to go to, like, I mean, if a patient decides, I don't want any further escalation of therapy, it's not like written in stone. So these goals of care can change at any time. So yeah, these are the things that will be considered. But for palliative care emergencies, I don't think there is any special need of a special consent form rather than this general things that we usually do.
Exactly. Explanation of the condition and goals of care. So that is why that is important, and any general consent form can be used. What does a consent form mean? You explain everything and make sure the patient understands. For example, that is where communication is going to come handy for you. We have been always telling there is something called as tell, ask, tell, not tell. I will tell you, just listen. No, you tell something, make sure the patient has understood that. So that is what asking is. Like tell, ask, tell, we say. So you tell something or explain, then ask the patient, have you understood? Can you tell it to me in some simple words that you have understood? So that consent form, that part is important. You do that and then ask them to sign, so that the consent form is the medical, is the black and white, which is going to help you in medical legal issues. Dr. Premnath, if you want to say something, please come up, and if the explanations what we have given has satisfied your query. And again, one more thing is goals of care is not like fixed. So you make goals of care. Goals of care are made by the physician and the patient and family all together. So you have certain goals of care. So this is what we will do. We have explained everything, had a multidisciplinary discussion. And these are like goals of care can be 5 points, 10 points. And then 2 weeks, 4 weeks down the line, either patient gets better. So of the 10 goals of care, I want to change 2. Yes, you change. Or then no, the patient has deteriorated further. So initially patient had said, okay, I may say yes to nasogastric tube. Then in the deterioration, patient has changed the mind and said, no, I don't want nasogastric. So that particular change can be made in the goals of care. So that is what Dr. Joseph was also trying to say.
Madam, what
So
I meant
with
was,
the
this, as long as we offer the palliative care in a totally charitable way with no kind of a free, then the issue will not come. The moment, suppose anybody charges, in all Western countries, the palliative care is not a charity at all. So you receive some consideration in return for offering palliative care, then the medical legal problem comes.
No, see, we are also been telling, I've been like palliative care need not be only a charitable job. It has changed in India also, doctor, to a very great extent.
Yes.
There are many centers who are, so everything having it clear in black and white is what will only save you. Okay, everything. So if you want these things to be done, yes. So see here in that, like from I don't know what I'll try to explain. So even for example, whatever procedures you want to do, they have a cost attached to it. So you explain for these things, even if it is private or free service, you explain these things can be done, and those, if it is a private one, you put in the cost also to that when you make the goals of care itself. Am I explaining it in sufficiently, Dr. Joel, or Joel Joseph, or you want to add on, you can do. If it is a private service, what is that his query is?
Yes, ma'am, absolutely. I mean, palliative care is, as you told, is no longer a charity in most of the institutions. We do give subsidies and discounts, but it's a proper proper medical care. We are not compromising on anything. So it doesn't mean that palliative care is always charitable. So, but we do give concession to patients and all those things, but this is proper medical care. And as long as you make your goals of care discussion proper and document it, I don't think there will be any confusion. But having said that, the situation in India, I don't know, there can be unpredictable things like people getting agitated and all those, that sometimes, somebody new people can come in. Those things that we cannot predict and prevent, but whoever is available with the patient. So the most important thing is always make sure that both the medical team and the family are on the same page. So there is no confusion regarding goals of care, and explain the probable causes of deterioration, the chances of deterioration, and how are we managing it. So having foreseeing it and explaining it to them, educating them, and being on the same page will solve most of the issues. That's what I feel.
Yes, foreseeing and foretelling. As I'm telling you, you will in your end of life care session, you will hear more about it. Explaining to them, making sure, see, good communication is what is going to help you. Truthful, good communication. Okay, and making sure you communicate and make sure that they understand, and that document that also. See, for example, when I've been working all the time, I will write who, like the discussion I'm having, who are all there in that discussion. Example, patient's son or So next of kin, and who else? Like for example, wife. I have explained all these to them. I have explained the patient's current condition, what can happen. So all this you have to document. See, clear document. It will take time. You will have to have few sessions. All these are more important. Okay. So if you do all that and document, and then good communication and rapport, confidence, everything is needed. And then some queries and issues and emotional outbursts, all that will happen. Give room and time for that, and then manage appropriately. Dr. Pushpa, you could unmute and speak what
Madam.
you want.
Thank you, madam. Madam, whatever said and done, whether it is charitable or paid, or whether we communicate and our communications are proper, but still what I feel that for our legal protection, it's better to document as you said. Plus, what about video consent? Video consent. Nowadays, lot of importance is given for video consent. From, I mean, whatever you are explaining, you can video it, and that can be used as a document.
No, see, black and white, yes. If you want to add on that, fine. Video, that means you should have, how are you going to document that video? It's all individual preference. Black and white documentation is what is always, because 5 years down the line also, if you want to have a video as an additional documentation or additional evidence, that can be used. No worries at all. And the one question in the chat box we'll take before we go for the case discussion: what is the protocol for home-based palliative care? See, again, that also is goals of care only. Home-based, see, home service, hospital service. There are these are two arms or two wings to your service. So that also you will, even for home-based palliative care, you make certain goals for that also. If it is a supportive care, and what team have you got to provide the home-based palliative care? Again, that varies from center to center. Some centers may have 5 teams. Some center will have only 1 team doing both home care and hospital care. So they are sharing and doing. So that one, it depends on the availability of the service, how much home-based care you can provide, and based on that, you make the protocol. So again, is there a set protocol? Is that what you're asking? Dr. Adan. Dr. Jewel, is there any set protocol for what home-based palliative care is provided?
No, ma'am, we don't have. So basically the thing is, there are certain things that can be done in hospital only, and there are certain things that can be done at home also. But the truth is, towards the end of life and such conditions, the difference becomes very thin and almost similar. So if you properly educate the family members, when the patient reaches a particular point of the life trajectory, so almost everything that can be done in a hospital can be done at home. So if you educate them properly. But having said that, the professional care and all those things are a different aspect. So whenever, I mean, if you foresee a long admission or something, so we basically sit down and explain to the patients regarding, so what are the things that can be done at home. So what are the advantages and pros and cons of being in a hospital or being at home? There are hospital-acquired infections and all those things, but there is availability of professional caregivers. So at home, there are your loved ones, your relatives, and it is your home, your familiar environment. All those things are there. So then the patient will usually make an educated decision. The patient or the family make an educated call. And whatever the patient, there are patients who prefers to be in the hospital or hospice. So that because there is inadequate facilities at home, there are not enough people to take care, whatever be the reason. So what we are trying to do is, as ma'am told, we are setting the goals of care. We are giving all the options available, and we are giving the pros and cons of each thing. So if when that, let them and empower them to take an educated decision. That's what we are doing. So there are not set protocols for home-based care or hospital-based care.
Thank you. See, exactly. I will also reiterate and tell that in another way. That's all. I'm just use of English words in different ways. So basically, as Doctor mentioned, It all depends. I don't know, Dr. Aiden, no, like what type of home care facility he has. So basically, home care and hospital care are two aspects of care. Hospital care, everything under one roof. Home care, it depends on what team you have. You have a doctor, nurse, social worker, everything for that particular team which goes home. Well and good, you can provide a good service. Again, you have here a very great extent lies on what is that you have told the patient. You have to tell them what is that will happen at end of life care. Many people don't know, so they are like fear of the unknown. So I don't know what will happen. How will I manage at home? So if you explain to them this is what, and then again the pros and cons. Being in hospital, everything is done by someone, but being in an ICU, how many nearly the dearest are they with the person who is unwell? No, some are not even entering the whole ICU unit. So from that point of view, being with loved ones is what they want. Like long back, we have done survey. Like when you ask patients, where is that they would love to die? 90% have said that they would love to die at home. I did an audit some 10 years ago. So that is what it was, nearly 90 to 95%. See, just ask for yourself, what is it? You would love to be in a place where you feel safe and comfortable. And by being in home, the family and carers also have so much benefit. But if they are not aware of what will happen, what they have to face, how they will combat the situation, that is where the fear lies. So more education, awareness, what is that? So even in these emergencies, sometimes if it is an emergency which cannot be treated, so even being at home, they can manage the situation. So education, awareness, making sure that you are there on the other end of the phone, at least to give them some advice and support. So everything matters. So that is why I said it depends on what type of home-based service you are able to provide. If you're able to provide a good service, even giving advice over the phone from the other side and telling them this is what will happen in this situation, do this. So all this can be told to them. And then making sure that there is at least a nurse or a doctor who will communicate to them even when they call and ask. So all that is important. And that is where once you make the goals of care and this is what the collective decision has been made that the patient is happy to be at home and manage the care. So that can be it. Okay, we can go ahead with the case, Sangeet.
Okay, ma'am. Our case presenter is Dr. Vasha Sharma. Over to you, ma'am.
Thank you, sir. Good evening, everyone. Next slide. Okay. Here I'm presenting a case of 50-year-old male who was diagnosed with squamous cell carcinoma of right lateral border of the tongue with a stage of T4, N2C, and M0, presenting with hypercalcemia. Presently, the complaint of the patient is anorexia, poor oral intake, drowsiness, and confusion since last 2 days, and with deteriorating sensorium. History of presenting illness. He has a history of white leukoplakic patch on the right lateral border of the tongue, which developed in a non-healing ulcer even after 3 months. History of change in the sense of taste and difficulty in tolerating spicy food. History of difficulty in chewing, swallowing, and speaking and moving the tongue. History of swollen lymph nodes in the neck region. History of cigarette smoking, 90 packs a year. And he was taken to the hospital where he was diagnosed with squamous cell carcinoma of the right lateral border of the tongue with a stage of T4, N2C, and M0. Here there was the general examination was done where he was found with the poor general condition. He was found to be drowsy with no localizing signs. The pulse was found to be 98 per minute. The blood pressure was found to be 100 per 70 mm of Hg. Temperature was 98.4 degree Fahrenheit. The respiratory rate was found to be 11 per minute with slow and shallow breathing. The oxygen saturation was found to be 98%. The neurological examination revealed bilateral arthritis, and the cardiovascular, respiratory, and abdominal examination was unremarkable. Moving with the treatment and the significant investigation, we have done the electrolytic investigations where the ionized calcium, serum sodium, serum potassium, and randomized blood sugar level and total leukocyte count was found to be raised in comparison to the normal ranges. They were negative for the ketones in the urine test, and the chest X-ray, ECGs, and CT scan had no abnormalities found. So he was closely monitored in ICU for his vital parameters, blood sugar, serum sodium, serum potassium, and ionized calcium and SpO2. Coming to the psychological aspects, the patient is a 50-year-old male who lives with his 48-year-old wife and 26-year-old son in a village. He was working as a farmer to own his living, and but had to sell it to fulfill the expenses for his treatment. His son has to drop from the engineering college and has to work as a helper in the other shop. So the now only source of income was his son's salary. The patient was denying for the treatment initially because of the financial crisis, but they sold their land for his treatment. So in the treatment aspect, the medications, what was given was IV half isotonic saline hydration, infusion of KCl 60 to 80 milliequivalent per liter per day, injection of zoledronic acid 4 milligram over 15 minutes, injection of calcitonin 100 units subcutaneous every 6 hours for 3 days in succession, and insulin according to the sliding scale. And the patient was kept on the parenteral nutrition. The main concern of the patient was that the patient should regain the complete consciousness and improvement in the general condition of the patient. Now, to summarize, he's a 50-year-old man with squamous cell carcinoma right lateral border of the tongue, presenting with the condition of hypercalcemia. So the main point to be discussed is the patient requires emergency treatment before worsening of the condition. We need to observe any metabolic complications. The palliative care has to be provided to the patient after he restores to normal, and reassuring that his wife and son regarding the condition which has occurred. And thank you.
Thank you, Dr. Varsha. Dr. Joel Joseph, and we can go through each of your discussion points, how it was managed and what was his condition as we go through.
Okay, ma'am. How did the sensorium improve after treatment?
Yes, sir, the condition was improved after the treatment.
Okay, so he became completely coherent. So his sensorium became normal.
His sensorium became normal. He regained his consciousness. Actually, early he was not even able to recognize his child, but he regained it.
Okay, so the one thing I wanted to point out is he has hypercalcemia, and look at his sodium, it's 168. There is significant dehydration also, which can usually happen with hypercalcemia. So I think, yeah, you have corrected the hypercalcemia, his sensorium has improved. So one thing I wanted to suggest is, so further, since hypercalcemia is quite common in head and neck malignancies. So we need to again keep an eye open to that. Palliative care has to be provided to the patient after he restores to normal. So again, we need not wait until he restores to normal. So palliative care can be part of palliative care. So yeah, management of emergencies also can be part of palliative care. There are other concerns also that we may need to sort out here, no? So because he is working as a farmer, he has to sell it to fulfill the expenses of the treatment. So this is something that is correctable. Hypercalcemia is correctable, and you will be able to completely reverse it. So what lies ahead is maybe an important question to all of them. So any updates on his treatment? What is being done?
How is
So
he now?
currently
That's what
the
he's asking.
chemotherapy and radiotherapy is continuing,
Okay.
and the patient is fine, is under the palliative care only now.
Okay. Okay. So yeah. So hypercalcemia, that particular episode may be traumatic to the patient and the family, but again, that is a reversible thing. So that is not a long-term thing. So you were able to completely reverse it. So
Yes.
we'll have to look at the financial toxicity of the treatment of radiotherapy, chemotherapy, and this may not be a curable disease also because it's quite advanced. So he may need to continue some sort of chemotherapy, oral metronomic chemotherapy, something of that sort. So the disease response can also be questionable. So he may not get a complete good response also. So the treatment of intent, oncological treatment of intent can very well be palliative. So all those things needs to be addressed. So a social worker and a psychologist assessment would be necessary, I think, in such cases if that is available, because he was the only breadwinner of the family. So son has dropped off from engineering college, whether there is any provisions to continue his studies, because once he finishes the engineering college, he can get into a job and he can be a breadwinner to the family also. So initially the patient was denying the treatment. Then he had, the thing is, see, there are variable government schemes that are available which can be used for the patient. So whenever somebody is denying the treatment because of financial toxicity, those are something that can be explored. So whether there are other avenues of support for the treatment, such things can also be considered. So yeah,
Thank you.
Yes, thank
Go
you.
ahead. Go ahead if you want
The
to add on.
management of hypercalcemia is concerned, you have tackled that well. Patient has regained consciousness, the calcium levels have come back to normal. But what lies ahead may be more challenging.
Exactly.
We know what exactly to do. When the patient lands up with hypercalcemia, there is no confusion. We don't know. We know exactly what to do. But what lies ahead needs a lot more planning, and there is a lot more uncertainties regarding that. That's what I feel.
Exactly. You just took it. See, the clinical emergency can be managed, and God's grace, unfortunately, reversal was possible here. Okay, so because that the correctable has been corrected, then comes now here the role of social worker and a psychologist, and also the medical team, also the parent team or whoever is his base oncologist has to be clear with them what are the options available, treatment options, and then you reassess. Okay, you give the treatment, there you have to have some time frame. You have certain cycles of treatment and see the response, whether the outcome, whether disease progression is going in the same way or there is a remission. So if remission is possible or not. So that is where the important thing lies. So there, that is why regular review, even if it is something really acutely bad, you have to review 24, 48, 72 hours. You have the same thing what we do for an acute situation, you apply for the chronic situation also. So see how his disease response is, then explain to the family about the condition, then the cost. Okay, and from cost point of view, as doctor mentioned, there are certain schemes which the patient and family may not be aware. There are many, each state has a health insurance scheme. So up to the maximum of what that patient can get from that scheme, we have to explain to them. And now there are these type of things which patients are not aware. There are organizations and people who are willing to help patients. So find them and connect them. And then comes what is the rehabilitation that you can give for the son, whether he can go back to his studies, finish and get a better job. Because that's why a social worker and a psychologist, because all this will be causing so much of psychological impact to the patient, to the carer, to the son. So that is where multidiscipline. Maybe can we come out of the screen, Sangeet, so that we can get into the discussion, if anybody else wants to add on. So multidisciplinary approach and then multimodal management. Anything else? What is that you could do from your point of view, Dr. Varsha? Do you have any of these facilities available? You said already patient is under a palliative care. So is there a psychologist? Is there a social worker?
Psychologist, I have a doubt, ma'am, but we have certain organization who can fund for his treatment part.
See,
So
that's
we
what.
can connect to them.
So,
We can connect
so
to them.
has he been connected to them?
Not yet, ma'am, but certain government policies and certain funds, ma'am, it takes a lot of time. So it's in the,
Exactly.
so that is why we have told about that, but it all on the depends upon the government and the processes which takes place as soon as possible. So
Exactly. So in these type of logistics, no, the time is like a delay is not in patient's favor. So those also have to delay, and many times you have, for example, I'm telling 5 lakhs. See, the treatment may need 8 lakhs. Okay, but the 5 lakhs is where the limit will come. So all these things have to be explained, and we as a team, everyone has to be aware of it. So somewhere abruptly stopping, how much? So you have to anticipate all this, have discussions.
yes, ma'am.
So availability of scheme, availability of limits in treatment cost, or limit in the funding, or you connect, because see, there are schemes, like not only there are schemes for radiotherapy, there are schemes for chemotherapy. The same chemotherapy, one full treatment cycle may cost in one amount in one center. The same treatment can be done for a different cost by some other charitable scheme. So
Yes,
all
ma'am.
these, I think all of you are also available. All these, aware of all this. These are available all over India. So
Yes.
so these you have to be aware and connect and guide them appropriately.
Okay, ma'am. Sure.
So those are things from this patient point of view, you have to explain and link them so that they're able to get, and then they make a decision on what or where, in which direction to move forward.
Yes, ma'am. Sure.
Anything else you want to add, Dr. Joseph?
Nothing, ma'am, nothing.
Okay. Anybody else wants? There's nothing else in the chat box. So if anybody wants to unmute and ask, please do.
During these consultations, if patient is slowly deteriorating, have you, like, you have been in, all of the speakers have been in practice, so do the caregivers go through mental breakdown, or do they have suicidal tendencies or guilt of not being able to cope up, like because in hospital at times we are not able to see that, but in long-term care facilities or palliative care units, what's your experience and guidance for us?
Hello, ma'am.
Go ahead.
Yes, yeah, we do see those. So, I mean, thank you for bringing that up. That brings one of another important aspect of palliative care, that is bereavement. So, yeah, we'll have to be, it is like a comprehensive care, not only directed at the patient, but at the family also. When the patient deteriorates, the family can go through breakdowns and all those things, the stages of grief and all those things are there. So that is when the multidisciplinary, two things I wanted to stress is that is when a multidisciplinary team comes into play. So the doctor may not be able to manage all these things. So a psychosocial, psychologist, a social worker will be very valuable in such situations. The second thing is, even after the patient passes on, so the family is the one who is left behind. So bereavement is another important aspect of palliative care that needs to be taken forward. Yeah, thank you.
And sir, Harrison's.
Go ahead. May I know who is speaking?
I'm Archit from Noida.
Okay. Go ahead.
Sir, Harrison writes in the chapter of palliative care, like death of a patient is an independent risk factor for death of the spouse. And second thing they mention is like in their culture, they make it a point to attend the funerals of the patient who have passed away. So they have written, like the authors of the chapter have written, it gives a opportunity for the physician to undergo the closure. So this is what the American system of medicine says. So is this really true in your practice, or in the context of Indian settings, which is more multicultural and which is more vibrant, at times more difficult also?
I'll speak about our institutional experience. So after
Yes, you go ahead,
patient-
and then I will tell what happens in Palliative.
Yes. Yes. So in CMC, our institution, what we usually do is we give a bereavement call to all patients after they pass on, because whoever has seen that patient the most, and whether it is a doctor or a social worker, whoever has the best rapport with the family, we do give a bereavement call. So if that patient is a local patient, so we make it a point. Our social worker does a local. We, in the sense, we have a radius of around 50 to 80 kilometers around the hospital where we do home visits. So if the patient was a local patient, our social worker will do a bereavement visit to the family. And if there are any areas where we can actually help, we also do that. So with some job opportunities, or for like a family business or a tailor, like we have given some tailoring machine. So the small things that we could do to help them through that process. That is what we do. So I mean, if it's not like a comprehensive thing, but again, we try to do our best.
Thank you, sir.
Thank you. See, like, for example, I'm going to go back to like day one when you had what is palliative care. There was a diagrammatic representation of palliative care. So we said palliative care it is best to start early along with curative care and go on till end of life care and bereavement also. So palliative care complete is in which bereavement is included. It is practiced. Wherever palliative care is done, bereavement care is done. Okay. And it is not only at the time of death alone. It goes on for in some places for few months, because bereavement as such, can be like bereavement as there is something called as in grief, anticipatory grief. Once they know that the patient is going to pass away, it starts on, okay, and then it can go on even up to a year. And you said a golden statement: the spouse is the person who will be affected by it for a very long time, and the effect can go on for easily for a year. So bereavement support itself goes on for a longer time. As doctor mentioned, not only by a phone call, a visit is done. For example, in Pallium, I'll tell what happens. So visit is done, then a team goes home and make sure spends some time, not just few minutes, spends some time with the family, and has a home visit. And after that, something else also happens. They have a regular bereavement meeting type of thing where they get all patients who have lost friends and family. And it goes on. Unarvu, I think that is the name of that meeting. And it goes on for few months. And the families, the carers from that each meeting, they make groups, they share, and those type of, see, that is how you're going to give them help and support. So always these type of group events brings about something very, very important. Many people have a feeling it is me, the only person suffering. When they come to a group and see these type of things, they have they themselves form group. They say, oh, it's just not me, one person singly suffering in this whole world. There are people like me too. So that also gives them a better feeling. So this, not only for bereavement, we used to use this as a tool for any chronic pain issue also. So many people think that I'm the only person, I'm unable to do this, so I don't know how to manage. So when they come for these group activities, it opens up for them and gives them an idea, oh, it's just not me. I have many more people. So they form groups. They feel, oh, I can manage. So the same aspect is done for bereavement also, and it's a long-term process which is being done. As Dr. Joseph mentioned, it is done by any palliative care service which is running does have a bereavement. Only thing, again, I'll come to one thing: availability of resources. If you have a good resource team, you can have if you have a good social worker department and a psychologist department, so they can form part of the team for that bereavement support service. And they can take it on, they can deal all the issues. Like grief is one of the important issue to be dealt with. Then financial situation, social situation, all these three can be dealt if you have a team who can manage these: social service, social support, social community support, and also a psychologist. Then based on this, social team will look after the financial support, their rehabilitation, what can be done to what extent. Okay, have I answered your queries?
Yes, ma'am.
Thank you. And
Thank you so much.
do you already work in a palliative care department?
No, ma'am. I work in a pediatric hemato-oncology department, so
okay. No, see,
it
for
becomes
even for
very
pediatric,
difficult at times because actually parents become very what word should I say? Maybe hapless when it comes to the end of life of the child.
A pediatric, for example,
And,
pediatric service also, Pallium already has they have tie up with the government set up in Trivandrum. They have expanded, and that also is equally important. See, for the parents, that child, and then if it is a pediatric thing, you also have to consider about siblings. What impact it will have on the siblings. Like spouse, no, siblings will have a very big impact. So sometimes you cannot avoid, you have to, like explaining to a spouse, you have to explain to the siblings also. So pediatric service also, a large amount of work has been done, and all these facilities and services are given for the same pediatric team also. See, every specialty. That is why another important thing now is palliative care is just not only generalized palliative care, subspecialized palliative care is also improved. Okay, so pediatric also has got a, no worries, pediatric care also is there, and you can get in touch with Pallium like Sangeet, you can link him with the pediatric palliative care team in Pallium, and he could get whatever help that could be obtained.
Okay, ma'am.
Thank you, ma'am. Thank you so much.
Thank you very much. Over to you, Sangeet. There are no more queries and questions in the chat box. Over to you. Thank you, Dr. Joel Joseph, once again.
Thank you, Dr. Joel Joseph, for the wonderful case presentation. Thank you, Radha ma'am, for facilitating the sessions very well. Thank you, Dr. Varsha, for presenting the case presentation. I think Dr. Sangeeta can help with Dr. Achit Bhan.
Yes. Please link him with Dr. Sangeeta,
sure.
And they can, then he could get what is that he could do. For sure. Pallium could help him to improve his services.
Sure. I'll get in touch.
Thank you.
Thank you all. Thank you for joining the sessions. Thank you. Let's see in the next session. Bye.
Thank you.